Good evening. Welcome to our Facebook forum tonight. The intention tonight, welcome to everybody, is to talk about artificial intelligence in the IVF laboratory. But before I do that, what I'm going to do is I'm going to talk about what happens in an IVF cycle and then explain to you where artificial intelligence fits into all of it. One of the first principles that applies when a couple decide or a woman decides to go through IVF is that every time a woman has a period, she has a number of eggs that are growing in the ovary. And each month, a woman, when she has a period, will grow 9 or 10 eggs at the start of the month, but only one of them will go on to be released. So the purposes of the medications that a woman takes during IVF is to stimulate lots of eggs to grow so that all of the eggs that she has keep growing and carry on developing during the cycle. And then she takes a second lot of medications to control her own hormones to ensure that the eggs aren't released prematurely. So as she goes through the cycle, and I've got a question here from Tabish. Do you want to fire away, give us more details about your question, Tabish? But as the woman goes through the cycle and she has the 2 lots of injections, the follicles grow. Now, follicles jargon, what follicle is a bag of fluids with an egg in it. Yes, please, Tabish, do ask your question, because we want this to be an interactive forum so you can put questions in, and that will allow me to provide the information that's right for you as we go through all of this. So the woman's going through IVF and she's taking 2 lots of injections. 1 lot of injections to stimulate the follicles containing the eggs to grow, and 1 lot to control her own hormones so she can't release the eggs prematurely. And during that time, the woman will have blood tests and ultrasound scans done, and that will allow her fertility specialist to monitor the growth of the follicles until the eggs are ready. Once the eggs are ready, the woman will then take a different type of medication to stimulate the eggs to mature. The woman then comes in and has a procedure done to have the eggs collected. Now, one of the great challenges in doing IVF is that not all eggs are the same. Some eggs are good and will grow well and end up as good eggs, while other eggs will not grow so well and will be of poorer quality. And we've got a question here asking me for what is my advice to improve egg quality, and that's a tough thing. What we know is that every woman has some good eggs and some bad eggs, and that happens to everybody. There's no such thing as a woman who has entirely bad eggs. There is no evidence that substantially supports any particular treatment for improving the quality of the eggs. But people do try different things. People try things like vitamins such as CoQ10 or melatonin. People try medications such as DHEA, which is a mild form of the male hormone. Now, none of these approaches have any evidence that they make any difference at all. But sometimes one of the challenges of IVF is the sheer powerlessness of it, and many women will choose to try these different options. One question here is a question from Tabish, who says, they have 2 girls, and if they want a boy, can they go for IVF, as his wife had a miscarriage last year? One of the challenges in Australia is that the whole question of using IVF for sex selection is a very difficult area indeed. It's clearly a very sad thing to go through a miscarriage. It's the sort of experience that rips your heart apart when you go through it. But there's no evidence that whether you have a boy or a girl will change your risk of miscarriage. And under the ethical rules under which we operate in Australia, you're only allowed to use the technology that allows you to choose a boy or a girl if there's a serious medical condition that this will improve. And sadly, a miscarriage is not a medical condition that would be improved through choosing the sex of the child. So in this circumstance, Tabish, I'm sorry that in Australia you would not be able to go through that and use that. Okay. Here's a few questions coming in, a little bit off topic, but heavens, we're here for a bit of fun, so let's go off topic a little bit. Catherine has written to ask about how much the removal of superficial endometriosis improves IVF success rates. It is an area where we don't have a lot of strong research evidence one way or the other. We do know that removal of endometriosis from the ovaries does not improve IVF outcome one little bit. There is some evidence to suggest that if you have superficial endometriosis removed, it does improve your chance of getting pregnant naturally. But whether that applies to IVF or not is still very, very unclear. And my personal view is I don't think that removing a small amount of endometriosis makes any difference at all to IVF outcomes. It does, however, help women who suffer from pain from endometriosis, which can be quite awful. And it does have a small effect on natural conception rates. So there are often cases when you should have your endometriosis investigated and looked into. So Amy, you've now asked me about recurrent implantation. Now we are off topic, and immunology and the Bondi protocol, which, as you quite rightly point out, has had mixed responses. Again, this is an area where evidence is quite contradictory. Some patients do use these approaches and get success from them, there's no doubt. But whether it makes a significant difference to helping women have their baby or not in the long run still remains unclear. Now we're getting some questions in here about Ivy and the artificial intelligence system. And I think what I will do is I will keep going through this. And Amy, thanks for the nice comments about my accent. That's very nice of you to say that. So what I'm going to do now is I'm going to keep talking about where artificial intelligence comes into the whole IVF picture. That what happens with IVF is that a woman, as we've said, will have a number of eggs collected, and these will be grown in the laboratory. So for example, if a woman starts with 10 eggs, she may have 6 or 7 fertilizing and end up after 5 days in the incubator of 3 very nice looking embryos. So the question is, which one do you choose? One of the great developments of the last few years has been the development of much more sophisticated incubator systems. And these sophisticated incubator systems allow the embryos to grow without being touched or without being moved. And what that means is that the embryologist doesn't have to take it out of the incubator, handle it each time they want to look at the progress. Instead, these modern incubators have beautiful sophisticated cameras that take a picture of the every 10 minutes. And that way the embryologist who's looking after your embryos can see how well the embryos are going without having to touch them. So the embryos stay in their incubator without having to be moved at all, which is inherently a good thing. However, we get a lot of information from this, but we still haven't been able to work out how to use that information to tell which is the best of the 3 embryos until now. Because what's happened is that our scientific director met this brilliant young Vietnamese medical student, and what he did was he developed a system using a giant computer, where the giant computer went through all the images of every embryo, looking at 10,000 embryos, taking a picture every 10 minutes over the 5 days of growth. And that pooled all these strange images together and produced a very powerful predictor of which embryo is going to give the best chance of turning into a fetus with a heartbeat, which is what we're all wanting to see. So we've developed all of that and tested it on 10,000 embryos. It is by far the most sophisticated artificial intelligence system around for doing this. There are other systems that exist, but these are based only on one picture at the end, or they've not been validated against the heartbeat at the end. The only system around in the world which has been tested against the heartbeat and which uses all 5 days of the embryo's growth, giving the very high predictive values that we get, is Ivy, the one that we use here across our clinics in IVF Australia. And that's why it's a much more powerful tool than any of the competitors. However, we still don't really know about how much that improves patient care. So we're currently involved in a very large randomized controlled trial to investigate what effect this has on our patients. Because after all, it's not about us having great tools to play with. It's about what we can do to help you, our patients, get a baby more quickly. And what we're doing is one of the questions is, what's the difference between Ivy, the tool that we're using at the moment, and IDA, which is the new research project? Well, IDA is really Ivy version 2. IDA has been tested out on 100,000 embryos rather than the 10,000 with Ivy, and is the latest generation of this tool. It's not yet available for routine use, but we are carrying out this research on IDA, the advanced tool for this. Hi Fiona, do we use Ivy to select embryos in all cycles? Yes, we do. We use both the Ivy tool and the embryologist's own opinion, and we get the best of both of these. Now, what you also have to remember, however, is we've only had Ivy for the last 18 months or so. Before that, when Ivy wasn't around, it hasn't collected the information from any embryos that are older than that. So it's a relatively new tool. Now, Tash has a question about SYN3. Does SYN3 affect your chances of IVF? And the answer is no, it doesn't. It's a very, very common thing to have concerns about your pap smear and to have treatment for it. But the good news is it does not affect your fertility at all. Now, Amy has also asked the question about patients with low testosterone and whether they need treatment for low testosterone prior to an IVF cycle. And the answer is we don't really know. A low testosterone level does not appear to have a major effect on most women, and that's why we have to be quite careful about that, because although we can see no effect on a large number of women, it is possible that giving a little bit of testosterone may help more eggs to grow, and there's some evidence for that. One of the challenges in all of this, however, is that every woman is different. Some women will find that they use a little bit of testosterone and find that their eggs get better, while other women use the same thing and see no effect at all. It's quite variable. And one of the challenges is that testosterone level in your blood goes up and down all the time. So you may find you've got a low testosterone one day, you check it again a few days later, it's actually okay. So it's a difficult thing to have much clear advice about. So let's work through some more of these questions. Here's a question about, does this information technology have any impact on women who are using pre-implantation genetic testing? So before I answer that question, what I'd like to do is to explain to all of you, what is PGD? What does it actually mean? Well, PGD stands for pre-implantation testing of the embryo. The most common situation where that's done is where you take a few cells off the outside of the embryo to check that all of your embryos have the right chromosomes in them. And inevitably some will and some won't. And if an embryo has the wrong number of chromosomes in it, then it's certainly not going to work and give you a baby. The technology of pre-implantation genetic testing is, however, still a little bit tricky because it's not a perfect science. What we know is because it's testing the cells on the outside, and the bit you're interested in is the baby bit in the middle, it's not always the same. And we know that if you get a genetic test done that says that your embryo has the right chromosomes, then it's always correct. However, there are occasions, have been reported, where the embryo suggests that it's got the wrong, where the genetic test suggests that the chromosomes are wrong, and people have gone back and tested the actual baby bit later on and found that it's actually not the correct answer. And people think that we're probably over-diagnosing genetic abnormalities in these embryos, roughly around about 1 in 20 embryos. So people are losing some embryos, small number of embryos that otherwise might have given them a baby. So it's a complex thing to understand what the benefit is of the genetic testing. Undoubtedly, if you've got a lot of embryos, particularly if you're older, that may be a very useful thing to do, to get rid of the embryos that have the wrong chromosomes, that aren't going to survive. They're not going to work anyway. This is not eugenics. It's simply taking embryos to one side that have a lethal chromosomal variation, and you're using only the ones with a chance of implanting. The effect of that in the context of looking at artificial intelligence systems is that you have to interfere with the embryo usually on day 3 to hatch it, to allow you to do the testing. And that distorts the artificial intelligence parameters. So it means that you can't use artificial intelligence to assess the embryos if you've already preparing the embryo for pre-implantation genetic testing. Here's a suggestion that light may be harmful to the embryo used in conventional incubators. Now, that's an interesting point because there's certainly no suggestion that the light is harmful to the embryos. However, the second point made here, that some scientists don't feel time-lapse imaging is superior to conventional incubators. That is the area that we have to understand better. People have done a number of randomized controlled trials comparing conventional incubators to the more advanced embryoscopes. And while we generally feel that it's a good thing to leave the embryos in these advanced embryoscopes to avoid handling them, the randomized trials so far have not found any benefit from using the embryoscopes compared to the conventional incubators. However, the problem with that, though, is that people have not necessarily used the embryos properly. In other words, what they're doing is just growing the embryos in the incubator and using exactly the same selection techniques. That's why we need to do this study that we're involved in at the moment, where we take the first technique that's been shown to be better at choosing the embryo and seeing if that can improve the outcome for our patients. So that's why we think this is a very important trial, not just for artificial intelligence, but also to understand whether the embryoscopes really do make a difference. Because our gut instinct is that they do help, but as Catherine's pointed out, the evidence still isn't there for that. Here's another question that's off topic, but still really important. Can a 4 by 4 by 6 millimeter endometrial polyp affect my fertility? It's so small. I think you're right. I think it's probably too small to affect your fertility in a serious way. Generally, a polyp needs to be about 1 centimeter in size before it has a significant effect on fertility. A polyp is a small fleshy growth which happens on the inside of the lining. Sometimes they can be very big, sometimes they can be 2 or 3 centimeters in size, and in that circumstance, a woman will normally get abnormal bleeding and other complications. A small polyp, many women have them and never know they've got them. But what's now clear, if a polyp is bigger than 1 centimeter, it's not a cancer, it's just a small fleshy lump. If it's bigger than 1 centimeter, it affects fertility. But I agree with you, Pam. 4 by 4 by 6 is pretty small, and I would recommend that you don't need to have anything done about it. Okay. Here's a question from Claudia, who's asked about embryos that are frozen. And she's used 3 embryos and birthed 3 children. Wow, that sounds fantastic. Excellent. Is it still the same that the remaining embryos stored cannot be tested for the sex? So I'm assuming your 3 embryos may have given you 3 children of the same sex, which can be, because a lovely thing to have children. And when people are struggling to have a family at all, you're very blessed having 3 children, but it does create a problem because everybody's dream is to have a mixed family with boys and girls, and that's a very important thing, and it's a very realistic thing that people may want to balance their families. However, as we've already discussed this evening, it's just not possible under Australian legislation for us to test embryos for the sex and choose the embryo on the basis of the sex, unless there's a serious medical condition present. Now, can I ever see this changing down the track? Well, maybe, but can I see it changing in the next 5 years? No, I think that's very, very unlikely. It's an area that's quite controversial in the community as a whole. And we, as fertility specialists working in this area, we have to be guided by the community in these very sensitive ethical areas. And there's no doubt at all that there are views for and against this approach of allowing people to balance their family by doing gender selection. But generally, on the whole, the majority of views seems to be against this use of the technology to do this. I've got another question here about whether we're able to share preliminary results of the IV technology. Well, we have already shared preliminary results. We published a paper last year where what we did was we looked at the predictive value of being able to choose the embryo. And we found a very, very high predictive value of a heartbeat by using the artificial intelligence system, much, much better than an embryologist choosing it. Now, doing that sort of retrospective study where we look at the predictive value of a technique is not the same thing as knowing that we'll actually improve the outcome for our patients by using this technology, which is the purpose of the research that we're doing at the moment. And while we've started this recruitment for this project, we're not in a position yet to report any data on any of that yet. But nonetheless, as soon as we get this data, then we will share it with everybody. What sort of rating does IV give the embryos? It gives it a grading. Now, it is a form of a percentage, and for most situations, the percentage is approximately correct. But sometimes it's not correct as a percentage. So we're steering away from using the information IV gives us to give a percentage chance of the embryo working, and instead using it mainly to rank the embryos, to talk about what is the best embryo and which embryo has a lesser chance of implanting. And it's clear that when we do this, IV performs better than an embryologist is able to, because remember that the embryologist is only seeing the embryo at the very end of its 5 days. It's looking at how well the cells have formed, and when grading an embryo, many of you will have had the embryologist talk to you about the grading of an embryo. And the embryologist will grade the embryo by looking at the little cells on the inside, the baby bit, and we'll look at the outer cells on the outer bit. And we'll give each of the inner cells and the outer cells a grade of A, B, or C, depending on how healthy the cell looks. They will also give the embryo a number. When the embryo gets to day 5, it starts off at the end of day 4 as a little ball of cells. And then during the course of day 5, a little fluid-filled cavity starts to appear, and it forms what's called a blastocyst because of the fluid-filled cavity. And so the further on, the bigger the fluid-filled cavity is, to the point where the embryos actually start to hatch by itself, the better the embryo looks. So it gets a number for that. And the number starts with 1 for an embryo that's just got a tiny cavity, through 3, which is a normal blastocyst, 4 is an expanded blastocyst, and 5 is a blastocyst that's hatching through the shell. So if you ask the clinic to give you the grading and they say the clinic is 5AB, it means it's a blastocyst that's hatching. It means the inner cells look beautiful, grade A, and the outer cells look pretty good as well at B. A's and B's are pretty good. C is a bad embryo that's got a much lower chance of taking than an A or B. Some clinics use 1s and 2s and slightly vary it. The A and B's is the internationally accepted system, named after our own embryologist here, Professor David Gardner in Melbourne, who's one of our team and leads our embryology team. And it's called the International Gardner Grading System. It's internationally recognized. So the question is, do you need to sign up to use IV? No, it's already in use for almost all of our patients. So most of our patients who come to our main core clinics, when the embryos go in the embryoscope, IV is running automatically in the background. So when it gets to the day of the transfer, your doctor and your embryologist will look at the grading system by looking at the embryologist, looks at it on the day 5, and they'll take the IV score into account, and they'll use both of these to choose the embryo that they think will give you the best chance of success. Here's a lady called Pam who's got a good AMH of 19.4. Remember that AMH is a measurement of how many eggs you've got. It's not a measurement of the quality of your eggs. It tells you how many you've got. And she's age 27. So Pam's been pretty smart. She's getting on to try and have her family as soon as she can, which is always a wise move. However, Pam's been trying to conceive already for 2.5 years, and that's a point where things start to get pretty tough. It's a point where you start to get down and frustrated. It's oddly enough, though, it's still a point where there's a good chance of things happening naturally. So is there a hope you can get pregnant naturally? Absolutely there is. If you've had all your tests done, and that's the key, if all the tests have been done and show that nothing is wrong, then that means you've still got a chance of getting pregnant naturally. However, the longer it goes, the harder natural conception gets. And usually, if you're at that sort of age of being relatively young, I would keep going for a bit longer yet. But I think once you get to 3 years of trying, that is the time when I think it's reasonable to start thinking and considering other options. Now, there's not just IVF. Sometimes mild fertility drugs such as letrozole or Femara may help boost your fertility. Sometimes doing artificial insemination with your partner is easier than doing IVF. But the drawback with artificial insemination is you're still having a lot of blood tests, a lot of scans, a lot of hard work, and a lot of emotions through all of this. But we're still with a relatively low success rate. So a woman who's age 27, who's been trying to get pregnant for 2.5 years naturally, has a success rate each month of getting pregnant naturally of about 3%, which sounds awful. You go, oh my God, only 3%, that's terrible. But if you think about it, 3% per month over the course of a year is still a 1 in 3 chance that you'll fall pregnant naturally by this time next year. So if you take a mild fertility drug, which makes you produce 2 eggs at a time, instead of 1, that boosts it a bit. Artificial insemination has a success rate of somewhere between 10 to 15% per month. IVF for somebody who's aged 27 has a success rate of around about 40 to 50% per month. So no doubt at all that IVF is the quickest and most effective way to help get pregnant. But many people suggest that all we're doing with IVF is just bringing forward pregnancies happen more quickly that could well have happened anyway by themselves. So there's a lot of, it is important that when you've been trying naturally and your test results are all normal, and that can be a very frustrating position to have been trying to get pregnant for 2.5 years and to find that your doctor can't explain to you why have you been suffering for 2.5 years trying to have a baby, and you've had your hycosi done, that's normal, you've had your AMH checked and it's 19.4, that's all good, and your blood tests show that you're releasing an egg every month, that's all okay, and your periods are coming regularly, and your man has been in and had his sperm tested, and that's all fine too. What's going on? And that can be a pretty tough position to be in. It's very frustrating, but on the other hand, though, if you're in that position, it means that things can work out by themselves. So it's a more frustrating position, whereas if your partner's sperm count's really low, or a woman's had bad endometriosis damaging her fallopian tubes, and natural conception is not possible, and the only choice she has is IVF, that's harder, because at least if you've got normal test results, it leaves both ways open. And many women, after 2.5 years of trying, will come through and they'll do IVF to have their first baby, and then they find the second one comes along naturally. And that can very, very often happen. Why does it happen? Nobody knows. Nobody can explain that at all. Here's a question about the artificial intelligence from Rainbow. Hi, Rainbow. How are you? Good to hear from you. Does it work in ICSI? Yes, it does. It's not affected at all by ICSI. So it works for IVF or ICSI, works for frozen embryos, it works for young women, it works for older women. And that's often one of the most remarkable things about it, that all of you, everybody who does IVF is very conscious of the fact that age is a major predictor on whether IVF works or not. And that everyone knows that a 27-year-old like Pam has a much, much better chance of success with IVF than someone who is 42 or 43 going through IVF. So how does the artificial intelligence relate to that? Well, It seems that the artificial intelligence is completely independent of that. It looks at the older embryos exactly the same way as it looks at the younger embryos. So, and it draws the same conclusions. And I had a patient once, not that long ago, who came through, and she was 45 years old. And I said, "Oh, really? Do you want to do IVF?" And her husband laughed and said, "We'll just do it for her." And so we did. She came through, did IVF, because usually at that sort of age, I don't really encourage people to do IVF because the success rate overall is awful from that. So I usually don't encourage people to do IVF in that situation. But she was keen, so we did it, and we got the Ivy score. It was really high. And I said, "Ivy," and in the end, that embryo actually worked for her. Much to my surprise, the Ivy score predicted it, showed that she had a really good embryo. It's implanted, and she's now well on the way to having another baby at the age of 45. So occasionally it works, but I do need to put a caveat on that the vast majority of people who do IVF at the age of 45 have a really hard time with it, and it very rarely works. So it's a tough thing at 45. Now Marina has contacted us, and she's 42. Now it's a 42-year chance of success is an awful lot better than it is when you're 45. Even those 2 or 3 years makes a huge difference to things. And she's had a scan done that says that there are 12 follicles there. Now that's quite a lot in any circumstance. For a 32-year-old woman, that would be considered a reasonable number. At 42, it means you've got many more eggs than most women of your age do, which is a good thing. And the fact that you're still breastfeeding suggests to me you probably had a baby not all that long ago. And so these are both very good pointers to the fact that you may well be one of those women whose fertility remains good well into your 40s, and that your prospects for having another baby may well be quite reasonable. What we do know is it's much harder for a woman to have her second baby. Sorry, it's the other way around. It's much easier for a woman to have your second baby at the age of 42 than it is to have your first baby at that age. If you've got a baby already, that's a really positive thing for having another one. Here's another question. Is embryo glue used at all times in IVF Australia? Do patients need to ask for it? At the moment, we are running it only for patients who ask for it. At the moment, there's a small charge for that, but we are reviewing that policy because it does seem to make a small difference of about 3 to 4% to allow an embryo to implant. And as the research has become clearer on that point, we are heading towards using that for all of our patients, but we're not there yet. So do ask your doctor about it, about embryo glue when you're coming through. Rainbow, your next question on that thread is melatonin. You're currently using 2 milligrams of melatonin. Yes, you can quite safely increase that to 4 milligrams. It is, as you know, melatonin is the natural hormone of sleep. So please don't take it first thing in the morning. Do take it last thing at night because that's a much more effective way of using it and maintaining the rest of your life at the same time. What else you've got there? Yep. Okay. Does it help to increase egg quality? That's the great unknown. It's one of those things that people have reported from time to time. Women have taken it and have found their egg quality gets better. But is there systematic research on this? No, there isn't. There's no hard proof that it improves egg quality. It's just that some women have taken it and have found that occasionally it works. Other women haven't taken it, and they sometimes find their eggs get better anyway. So we don't really know for sure. But one of the challenges we've already covered this evening is that we have no proof that anything improves egg quality. And there's no harm in trying simple things like melatonin and CoQ10, other vitamins like that, because it doesn't do any harm. That's the important thing. Does IVF Australia, Amy's asking whether IVF Australia sees older women in the 40s. Yes, we do. We will very happily see anybody to discuss their fertility with them and to help you. But many people come to us for help because they're not getting pregnant. So we don't discriminate. We will take on anybody to discuss how we can best help. However, we will also be realistic. IVF is a very, very tough thing to go through, and we have to give you the facts about how likely it is to work for you. And what we know is that between the ages of 40 and 45, the success rate from IVF drops off very fast indeed. So the success rate for a woman who is doing IVF with her own eggs at the age of 40 is around about 20%. The success rate for a woman who's 45 doing IVF with her own eggs is about 1 in 200. So it drops off between those two ages very, very fast. It's one of the hardest things to talk to women about and to explain, because sometimes it comes as a real shock, a real bolt from the blue that things have changed in such a short space of time. That can be very hard. So we're always happy to help, but we will give you advice about the true success rate before you invest your heart, your emotions, and the money in an IVF cycle. Ultimately, it's your decision what you choose to do, but we're here to help you and support you, give you advice and give you the time and the space to consider that advice. But ultimately, we will help you. If that's what you want us to do, we will help you and support you. Belinda's now asking, is the IDA project only focusing on the first transfer? Yes, it is, because the idea is to try and speed up the first conception. Is it used in all the other embryos research project? Yes, it is too. So what we do with IDA is that we're ranking what we're doing with IDA is that we use it to rank all the embryos and put back the order put back the embryos in the order that IDA tells us, not in the order that the embryologist would tell us. And that's the comparison. We want to know which approach allows women to get pregnant more quickly, and because that's a very, very important thing. What was the Ivy score of the 45-year-old? It was 40 odd, suggesting that a 45-year-old had a 40% chance of getting a baby out of this, which compared to the figure I've just given you of 1 in 200 was extraordinarily different. We didn't believe it at the time, quite frankly. We thought it's just Ivy's made a mistake here. We thought it was wrong. But in fact, when she turned out getting a baby from that embryo, we realized that Ivy was actually on the money looking at the embryos. And it looks at the embryos very objectively. Doesn't care how old the woman is, doesn't care whether the embryo is going to be frozen up, just looks at the events where the cells move around the embryos during the 5 days and uses that to calculate how likely it is that the embryo will implant. And it clearly, as you get older, the embryos are more likely to behave badly in the laboratory because you don't have as many good eggs. And a younger woman, a 27-year-old woman, is going to be more likely to have embryos that do well. More of her embryos will do well. But it can still pick out the occasional embryo in a 45-year-old, which gives her a good chance of getting pregnant. So when should pregnancy start pregnancy probiotic? Once pregnant or before? It makes sense with any vitamins that you're taking for pregnancy to start them in the month that you're aiming to conceive. It's quite safe to take them beforehand. I'm not totally convinced by the benefits of probiotics in pregnancy. The evidence for it, again, is very thin, but many people do think it helps. And so if you're going to take it, you should take it at the time, so you've got it on board at the time of conception. So here's Kath, who's 33, has an AMH of 5, endometriosis and adenomyosis. Oh dear. After 3 cycles, collecting 3 eggs, a cancelled cycle, and 4 eggs, the specialist has suggested that she turns to donor eggs due to poor quality of the eggs. That's always a really hard situation because the AMH is quite low, suggesting there's not many eggs there. Endometriosis and a low AMH level is very commonly seen together. And what people think that endometriosis does is it eats its way into the ovaries. And remember, all the eggs are actually in the skin of the ovaries. So the endometriosis eats into the middle of the ovary. And as it does that, the skin gets destroyed and the eggs get destroyed. And that's a circumstance where endometriosis can be very bad for fertility. However, one of the questions we discussed earlier on was, does surgery improve that? And the answer is surgery doesn't help at all for that. Surgery, and sometimes surgery can make things worse. If a woman has their endometriosis too aggressively removed from the ovary, that can further harm the egg number. So most of the time, most doctors would not recommend that you remove endometriosis from the ovaries. different with superficial endometriosis that we discussed earlier on. Look, when you're getting low egg numbers, life is always harder. But most women still have 1 or 2 golden eggs in there. And it's always a really confronting situation when your doctor says that it's time to use somebody else's eggs to have your family. And many women find that a really confronting suggestion. And I have to say, I very rarely recommend that to people. Women will usually find this out for themselves. And it's a very, very tough thing to do. And the whole issue of donor eggs hits you between the eyes. Most women, when they first discuss donor eggs, leave crying because it was not at all how they had ever planned to have their lives. There are some women who have no choice. There are some women who have no eggs at all of their own left. And they know, sometimes from quite early on in their lives, that donor eggs is the only option that they have. And they get used to the idea. But it's very hard when you've gone through 3 IVF cycles like this, getting small numbers of eggs, but there's still a little bit of hope that your own eggs can do it. To then take the drastic step of going to donor eggs is a pretty tough thing to do. It's something you have to consider very, very carefully. There is no doubt, Kath, if you did a cycle of donor eggs, you would have a better chance of success than using your own eggs. But given that you're getting eggs, is the chance zero? Is this a completely lost cause? I would say no, it's not. And there is still a hope that your own eggs can do it, but it can be very, very tough. And donor eggs would give you a higher chance of success. And like many, many women who have that, and you hit so hard thinking about it, I see many women who just sit and cry when they're dealt with this awful scenario. But I also see the other side of it. I see women who have had to go through donor eggs and have used donor eggs to have their family, and they come in with their baby. They've been pregnant for 9 months. They felt the baby kicking inside them. They've gone through the birth process. The baby crawls into their arms. It's never anybody else's baby forevermore. The mother and child bond. And the women I come in seeing, I remember talking to many of them when they're contemplating donor eggs, find it so hard. But when they come in having had a baby through donor eggs, they're as fulfilled as mothers and fulfilled in having their family as anybody else you ever see. So there is light at the end of the tunnel. It's just you have to be comfortable with it as a plan. So give it some thought. Kath, get some other advice. Whenever a specialist gives you advice, it's always a good idea to go off and get a second opinion and can give thought to it as to whether you carry on a bit longer with your own eggs, at what point you give up on your own eggs, move on. It's always a very tough, difficult decision to take. So Sarah, your husband has just got home and wants to catch up on step 1, step 2, and so on, please. So the question is step 1 and step 2 of what? Fill me in a little bit, and I'll be delighted to give you more detail on it, on your question, and give you some more advice and help. Okay. So we've got Prerna here. I think I've spelled that, pronounced that properly. So Prerna's got PCOS and irregular periods, and she's 33 years old. Well, that's actually not bad news. We've talked a little bit about poor old Kath, who's had a tough time because she's got hardly any eggs. But when you've got PCOS, you're actually at the opposite end of the spectrum. Women with PCOS have got large numbers of eggs. And the problem they get is because they've got too many eggs. That means they don't release the egg on time. The hormones go down when they're meant to go up when they're meant to go down. But having lots of eggs, nearly everybody who gets PCOS gets pregnant in the end, one way or another. If your periods are irregular, what you probably need to do is go and see a specialist and get some mild fertility drugs. These are simple tablets that will allow your periods to become regular, will help you release an egg every month, and allow you, in most cases, to get pregnant yourself naturally, but with just simple fertility drugs. So the outlook for that is actually very, very good. So do go get some help with your hormones and a little bit of light fertility drug, and you may be pregnant before you realize it. Very good outlook indeed. That's much more positive, helpful situation, whereas Kath has clearly got a serious problem having only a low number of eggs. It's not without hope, but it does get much harder when you've got a low AMH than if you've got a higher AMH. Belinda's asking when you should stop taking melatonin. Well, you can really carry on taking it for as long as you like, and you keep on taking it. And usually, as long as you're trying, there's no harm in taking it. You should stop taking it if you're having trouble getting to work in the morning because you're too sleepy. But the rest of the time, there's no harm at all in taking it. Okay. I've seen some IVF patients have shared a short time-lapse video of their embryo development before transfer. Yes, you can ask for this. We do have these time-lapse images. Just have to ask the embryologist, and we'll be very happy to provide you with that. We just need a couple of days to download the video, and we can give it to you on a USB stick that you can have to keep. One question, Rainbow, and there's no limit number of questions you can ask. It's actually a good thing getting people asking me questions, because it means I don't have to talk to myself all night long, which is a good thing. So the question is, when is the right time for hysteroscopy and to see if tubes are not blocked, and also endometrial scratch after several unsuccessful ICSI cycles? So there's quite a few questions in that one thing. So let me go through this with you. A hysteroscopy is a very small operation. It involves a camera going through the uterus to examine the inside of the uterus. I think it's an easy thing to do. It's a very straightforward, minor procedure, and I think you and I should probably sit and have a chat about that, getting that done. You can't, however, tell from hysteroscopy whether the tubes are blocked, because to find out the tubes are blocked, you need to do a bigger operation called a laparoscopy, and that gives you very important information about natural conception. But when the challenge is getting embryos to stick, it doesn't give you much more that's useful. So often we would not necessarily do a laparoscopy because it is a much bigger procedure. The last thing in your text is endometrial scratch. Now, many of you who are on this thing will be very familiar with this concept of endometrial scratch. It used to be very, very popular. There was some preliminary research that was done that suggested if a woman has a scratch, i.e. a biopsy taken from the lining of the uterus in 1 month, it would make the lining more receptive to an embryo going back in the next month. And so that made it quite popular. The problem with the scratch, though, is it's not much fun having an endometrial scratch. That's quite an unpleasant procedure to have done. And clearly, if it makes a difference to your chance of getting a baby out of it, yes, women will do it. Women will want to do it. But there's always been a lot of debate about how strong that research had been. And early last year, there was a very big study carried out of New Zealand, which looked at this to see whether endometrial scratches really make a difference or not. And the findings were very clear that a scratch makes no difference at all to a woman's chance of getting a baby. So as a result of that study, it's really sort of died out of use. And clearly, as we've discussed already tonight, it's quite hard when you're trying to have a baby, and particularly if IVF is not working and you're having lots of embryos transferred and nothing is sticking, and the doctors can't tell you why the embryos aren't sticking, is a really hard situation to be in. And most women that I see in that situation are keen to try anything. Yes, as long as it's not going to do me any harm, let me just try it. And that's a very reasonable approach. But we've now got good evidence that scratch makes no difference at all. So ladies, please don't put yourselves through that. It simply doesn't help. Okay. So Kath has replied to think that there is some hope for it, because there's a little bit of hope. Okay. And Prerna has also updated us on her story that she's got PCOS as well as prolactinoma. Now that's all a bit hard, having that combination. That really will mess with your hormones. However, just like PCOS, prolactinoma is a pretty benign condition, and usually with the right medications, and there's some very effective medications around for treating that will give you a very good prospect of fertility, often with just simple tablets. So don't be too concerned about the prolactinoma. That's a pretty straightforward thing to have, and should be very easily treated by your doctor. And you should have a very good chance of getting a baby in the not too distant future. Can I share any difficult patient stories that have surprised you and were positive? Yes, I can. Let me share a story of a patient I saw not long ago who had gone through a number of miscarriages. She'd gone through 4 IVF cycles and had had 2 miscarriages. And she came through and we did a scan and didn't see anything at all. It was very sad. It looked like she was going to have another miscarriage. But one of the things we always do before we ever interfere with a pregnancy is we send her for a precautionary ultrasound. And she went for the scan at the expert ultrasound place. They looked and they said, yeah, there's nothing here. But then they looked carefully, and just in the corner was a little heartbeat. And she's come back, she's had another scan, and after 2 miscarriages and 5 IVF cycles, at the age of 41, she's on her way to hopefully having her baby. But she's past the hardest part of the miscarriage risk, and I hope that everything for her will go smoothly from here. And that was after having thought that she'd lost even this pregnancy, was a very, very emotional morning. It was a lovely, lovely thing to see. Here's another question about low testosterone. My personal advice, Amy, is I don't think that a low testosterone is really something that's worth looking for. I think most women who come up with fertility problems have their testosterone level checked because we need to make sure that she's not got polycystic ovary syndrome with a high testosterone. And a low testosterone is not something that in itself is important. We know that some women do benefit from having a little bit of testosterone, but not everybody. And that some women will try testosterone to improve the number of eggs that they've got. But a blood measurement of testosterone, I don't think, is particularly helpful in identifying who would be helped by having a low dose of testosterone. But it's something people talk about a lot, but the evidence that it makes a difference is really not particularly clear. Belinda was asking about natural killer cells. What is my stance on this? Well, Belinda, as you well know, I have opinions on some things. Natural killer cells is what the thinking behind this term natural killer cells. It sounds like a Quentin Tarantino movie, natural born killer cells, but it's actually nothing like a Quentin Tarantino movie. Natural killer cells are naturally occurring cells. They act in the lining of the uterus, and their role in the uterus is to help the embryo to implant. So they play a very powerful role in natural implantation, and they appear in the lining of the uterus after ovulation, and they grow in number as the cycle goes on very quickly. The question is, can a woman have too many of these natural killer cells? And the suggestion is out there that some women have too many of these cells, and by having too many, it means it's harder for the embryo to implant. And therefore, some doctors will use treatments like steroids to suppress the number of natural killer cells, either in the blood or in the lining of the uterus. My personal stance is, while I respect many of my colleagues who take this view and offer women these treatments, is that there isn't enough evidence around to justify that. And one of the things that I've touched on a couple of times earlier on this evening is, understandably, when women have gone through a lot of transfers and still don't have a baby from it, they want to try whatever they can. And I think that's very reasonable if the approach is completely safe. If you're taking some melatonin to improve your egg quality, or some CoQ10 to improve your egg quality, that's all quite safe. Or a little bit of testosterone maybe to improve the egg number. All of these are safe things, they don't do harm. But when it comes to taking powerful chemicals like steroids in the early stages of pregnancy without a clear medical reason for that, I do have some concerns, and I would normally personally not recommend that to my patients. But there are many colleagues who I respect out there who take a different view, and I respect their skills and their abilities and their right to provide a different medical advice to their patients. Here's Sarah talking about a baby growing in the tube and had keyhole surgery and had both tubes intact. And the issue is, once a woman's had keyhole surgery and she's had the ectopic loop surgically removed, now this can be a variety of different things. Sometimes the ectopic's already been pushed out of the tube, and therefore the keyhole surgery doesn't have to do any more operations on the tube itself. However, ectopics generally happen for a reason. When a woman gets pregnant naturally, the sperm goes up through the uterus, goes down the tube, meets the egg, and comes back the other way down the tube to implant in the uterus, in the middle of the uterus. When it ends up in the tube, it's commonly because there's already scar tissue in the tube that caused it to do that. So it's not uncommon that women who had an ectopic, regardless how it's been treated, then subsequently find it harder to get pregnant, regardless of the type of surgery that's been done. And nowadays, with modern keyhole surgery, quite sophisticated operations can be done to protect the tube and conserve the tube. But ultimately, a pregnancy growing in the wrong place, it can be caused by damage to the tube and can create more damage to the tube. So it's good to go and get your tubes rechecked after an ectopic to make sure they're not blocked, because if they're not blocked, things can still work out naturally, but sometimes even though they're not blocked, they can still be damaged, and that's not a great situation to be in. Okay. So Catherine is suggesting that her prolactin is elevated and was told it was due to stress. Once it was always less than 1,000. I agree that prolactin level of 500 or 600 is just a stress effect. It's not a sign of a large, dangerous pituitary tumor if the level is only that. Even 900 is probably still a bit of stress in the normal range. Does it affect your fertility? Well, the question is, does it affect your periods? If a woman's having regular periods every month and her prolactin's at the 500 to 900 range, it's having no effect at all. Prolactin affects fertility by stopping a woman from releasing the egg. So a woman who's got a very prolactin tumor, making a lot of prolactin, her egg release switches off, and that she can't have a baby because of this. And so a very high prolactin level affects your fertility. But I personally, if your periods are coming monthly, do not think that's a big factor in why you're having trouble having a baby. Here's a success story from Marina. Hooray, we like success stories. Just had a baby, age 45, after 12 unsuccessful cycles. Oh my goodness me. That must have been so hard for you. But donor eggs has come along and helped you. And I think it's marvelous. Donor eggs is such a confronting thing. And I'm sure you'll agree that once you've got the baby in your arms, the genetics gets forgotten about. You love your baby. The baby will never look at anybody else as their mother other than you, Marina. It's the only mum your baby will ever have, and that's a beautiful, beautiful thing. Are there any relationships between gut health and unexplained fertility? There have been studies and they find no relationship. There was a lot of discussion about celiac at one point, and there were small studies that suggested that women with celiac would be more prone to miscarriage, but the more recent research shows that that is actually not a real connection. It's not a serious connection at all. So it's very important to be healthy from gut health, and to get help, because the growing evidence about bacterial overgrowth is very important. But I really don't think that's a cause for the problems that you're having in falling pregnant at all. Okay. What can be done to help lining thickness and progesterone prior to frozen embryo transfer? Well, that's a very, very important question, because that's quite a common problem that many women have, that the lining at the end of what we know is that when you're doing a frozen embryo transfer, it's good for the lining to be 7 or 8 millimeters or more. But what we find is that some women have an endometrium of, say, 6 millimeters. It's quite hard to help. We can use more estrogen. The estrogen is the hormone of the first half of the month that makes the lining thicker, so we can try using more estrogen. And a lot of the time that will help and that will work. It's very important that you have testing done to make sure that there's no scar tissue inside the uterus, and to have appropriate surgery to treat that, because that's the most important thing that will make it harder for you to hang on to your embryo. But it's a common situation that women have. It's a common situation that women may well have a thin lining, but when the camera goes in, it looks perfect. It's totally healthy. And the suggestion is now growing that it probably doesn't matter very much if your lining's thin, as long as it's healthy. And that's the important thing. And the reason that pregnancy rates are lower in a woman with a slightly thin borderline lining is because some of those women have got quite severe disease, Other women don't know. Other women have got perfectly healthy, normal linings. So I think if you can get the line to 6 millimeters and you know there's no surgery, then I think I would go ahead and just do a transfer. A lot of women in forums, this is Tegan. Hi, Tegan, how are you? A lot of women in forums have said their AMH has gone up. You're right, it can't go up. But the problem is that the test for measuring it is not precise. And sometimes there's a bit of error in the testing. So it looks as if it's gone up, but it hasn't really. And how I would interpret that is to say, well, look, clearly one of the two measurements has to be wrong. So you take the average between the two and take it as being the average between the two measurements. But biologically, it can't increase because women are born with all the eggs they'll ever have. And all that happens is the egg numbers drop as you go through life. Hopefully, they drop slowly and not too quickly. But it can't increase. There's no process whereby the eggs numbers can increase. But the measurement for AMH, as Amy points out here, different labs do have slightly different levels. And the problem is it's not, most of the hormones that you measure are done by a very automatic process. So it's very standard. So if you get your pregnancy hormone or your estrogen measurement done in two different laboratories, the methods are so standard, they're going to be very, very similar. But AMH is a difficult thing to the laboratory to measure, and the techniques are very complex. So there's more variation in AMH between different labs. And I think what I would do to you, what I would say to you is to say, take the average. You've got two quite different measurements, go for the average between them and look at both of them. And also look at things like the scan findings. We talked earlier to a woman this evening who had 12 follicles in ultrasound. So that's an important part as well in working out how many eggs a woman has left. It's a different thing, but it's also an important measurement of the number of eggs left in your ovaries, particularly if they get two very different AMH levels. Hi, Beck, how are you? Good to hear from you. Catherine's asking, is there any harm in using progesterone in frozen embryo transfer from the day of transfer in a natural cycle? No, none at all. What we know is that you need to use progesterone pessaries when you're doing full-on IVF, because all the injections you take to stimulate your ovaries, when you stop those injections, your progesterone level comes down. So it's very important that every woman who's doing a stimulated cycle uses progesterone, because otherwise the hormones drop and the pregnancy rate goes down. In a natural frozen embryo transfer cycle, it's quite different though. When the woman's having her own hormones tracked, she makes progesterone herself. And one of the things that happens in life, much to the frustration of us fertility specialists, is that women get pregnant by themselves. So your own progesterone is plenty to hang on to the embryo. But in some cases, some unusual cases, the progesterone level can fluctuate a little bit. So doctors will commonly give you a little bit of progesterone just as a help, just to make sure you're not one of those women whose progesterone level is going to fluctuate a little bit. Hi, Sarah. Thanks for coming back with that information. So you're going for an appointment in July. So step one is to talk to the specialist and explain your case. So the specialist will then review all the tests that you've had done and help guide you as to what the right treatment is for you. And if you're already been told by a doctor or by your own GP or somebody else that you need to do IVF, the doctor will then explain to you what IVF is and will go through the processes involved in IVF and will give you time to understand what's involved and to make your decisions, weighing up all the pros and cons of doing IVF. So when you go for the appointment, the doctor will see you. If the plan is to do IVF, the nurse would then see you, and then you get all the preparation done. So all your tests are lined up, you've done your consent work, you understand the process that are involved, and the nurses have helped organize all your medications. And then once everything's set up, you phone when your period begins and you start doing the blood tests and the injections from there. So that all of that, all those steps, the nurses and the team at Wollongong will guide you through all of that and help you understand each step of the process. So at this stage, all you need to do is turn up at step one. If you've already had tests done, do bring them with you, because it saves the doctor from having to repeat tests. If you've already gone to the expense and trouble getting them done, then just bring them with you, and it'll save them getting repeated. And then the doctors and nurses will guide you each step from there. Hope your husband's happy with that response. Okay, right. So the next question is from Amy again. Is there any harm in using aspirin during a natural cycle without assistance after ovulation? But MTHFR, but heterozygous only. And that's important because MTHFR is a very common gene to have. It's a gene that has lots of variations in the gene naturally. And most of those variations are completely irrelevant. Most of the women who have a variation or what's called a mutation in their MTHFR gene are completely healthy, have nothing wrong. And when it says it's heterozygous, that means that each of the two copies of the genes is different. Remember that we all, as human beings, we've got 20,000 human genes that make us the people we are. And all of us in those 20,000 genes have got a few duds. We all have them. But we're kept healthy by the fact that we've got two copies of every gene. And most of the time, the healthy gene will override the dud. So you're perfectly healthy. And the only risk is meeting a partner who's got the same duds as you do, when there's a chance that your child could inherit both copies of the bad gene. And that would be a very serious thing. Now, MTHFR is like that. So if you're heterozygous, in other words, you've got one good copy and one dud, it probably doesn't affect you. But there's an extra test you can do called homocysteine to have that tested. Now, if your homocysteine level is up and you've got a serious problem with your MTHFR mutation, then you need to have special treatment using high doses of folic acid and possibly Clexane. But it's only a minority of women with MTHFR variations who have that. And for most women, you don't need to do anything at all. And is there any harm in using aspirin? No, there's no harm, but equally there's no benefit. If there's nothing wrong with your blood clotting system, there's no benefit in using low-dose aspirin. It doesn't help you get pregnant at all. Thanks, Sarah, and hope you are going to go well through all of this journey as you get started. Are fresh or frozen transfers more successful? They're the same. With modern freezing of embryos, embryos have a 96 to 97% survival, and we know that the success rate from putting back a fresh embryo or a frozen is exactly the same. There is no difference at all in that. Okay. So from all of this, I think we've been here for over an hour. I think I'm going to start wrapping up now. I do hope you've enjoyed it. It's clearly a very tough thing at times trying to have your family, particularly if you have some of the challenges that some of you tonight have had to deal with through all of this. There's almost always hope of some kind by trying different things. And for most of you, hopefully it will all end up well. But I do hope that this evening's session has been helpful and useful to you and given you some information that you need to guide you through some of the tough challenges that lie ahead. Okay. Good evening to all of you. Have a nice evening from here on. Good night.